Now we are.
Wonderful. Thank you so much for joining us today. My name is Devar Ardalan, founder and CEO of iVow AI, bringing cultural intelligence to AI chatbots. On behalf of Swathi Young, the CTO of Integrity M, and Women in AI, as well as Ali Brandenberger of The Bridge, I wanted to thank you for joining us today for a conversation on cultural AI, heritage, and healthcare. Before I share a more in-depth introduction about why we're here today, I wanted to turn it over to my co-moderator, Swathi, to give us a bit more background about herself. Swathi?
Thank you, Devar. Hello, everybody, and welcome again to this another session of Munch and Learn about cultural AI. We've been having a series of events, and stay tuned for upcoming events in the next couple of months. So a little bit about myself, been a technologist for over 20 years, started off as a software developer, and most recently entered the world of data science, and I'm a practicing data scientist, currently Chief Technology Officer of Integrity Management Services, a healthcare company. One of the privileges I recently had was co-authoring the AI playbook for the federal agencies who need help to implement AI solutions, and currently co-authoring ethical AI framework as well. I'm very happy to have you all, especially the esteemed guests and Devar, for putting this event together, where we have to talk about cultural AI. That is the need of the hour. So over to you, Devar.
Thank you so much. If you could all kindly put yourselves on mute, that would be super. So we know that patient-centered, culturally sensitive healthcare has proven to show better compliance and results in improving clinical outcomes. I will be sharing these links of these studies in the chat so you can look at them as well. Research shows that empowering patients to share their views concerning culturally sensitive healthcare is a manifestation of patient-centeredness. Furthermore, the NIH All of Us program, inspired in 2015, is now fully in place and meant to build the largest and most diverse health research program of its kind. We're honored to have someone from the NIH All of Us program here with us. So using AI tools, how can we bridge the gap between patients and healthcare providers and advance a more culturally competent landscape in healthcare? According to Gartner research, by 2021, some 15% of customer service interactions globally will be handled completely by artificial intelligence. There are other studies that show that by 2022, 25% of our online interactions will be done through virtual assistants. And the key to success with emerging technologies has always been to enable experimentation and learning. So not only does that help refine strategy, but also gives you the ability to decide, around direct investment when it comes to returns and the way people are using these technologies. So why wouldn't a patient personalize their hospital chatbot or virtual assistant in their room to share roomy poetry to them while they're in bed? Why wouldn't a doctor ask a chatbot in her office to tell her a quick story about Diwali ahead of treating her cancer patient who just landed from India during Diwali festival? Why can't AI health agents be culturally relevant and programmed to improve with each experience? So to step back, I was a journalist at NPR News for many years. My last position at NPR was senior producer of the Identity and Culture Unit. And later, I was deputy director of the White House Presidential Innovation Fellowship Program. Throughout these experiences, I've understood the power of storytelling and the importance of cultural relevancy. That's why I started iVow AI. So Swathi and I are members of the Women in AI international group, and that's how we came together to put this virtual series together. I will also share a blog post so you know some of that background. I would like to now give each of our amazing panelists 1 minute to introduce themselves. So we're going to start with Kirsten.
Hi everyone, my name is Christine Monkhouse. I am the founder and CEO of Patient Orator, where we're working on empowering the voices of underserved communities and bridging the gap between healthcare resources and the chronically ill through a mobile health application. My background is in public policy and public health, and I'm also the creator of a documentary called Humanizing Healthcare, which discusses systemic issues in the healthcare ecosystem and a call from Americans to humanize the healthcare system.
Amazing. And Michelle?
Hi, everybody. Thank you so much, Devar and Swati, for the invitation. My name is Michelle Holko. I am currently serving as a Presidential Innovation Fellow working with the NIH with the All of Us Research Program. So the All of Us Research Program, in case you're not familiar with it, it's a cohort study that's led by NIH that grew out of the Precision Medicine Initiative. And it aims to enroll 1 million participants from diverse backgrounds from across the United States. The goal of the program is really to collect data from diverse participants to enable precision medicine research, because currently the way that medicine is practiced is kind of more of a one-size-fits-all method. And so we would like to contribute to the ability for clinicians to make more individualized and personalized recommendations. We're collecting a rich data set, including electronic health records data, survey data, physical measurements, biosamples for genomics, and other data, as well as data from digital health technologies, and then making these data available to the research community.
Amazing. And Shireen?
Hi, I'm Shireen Adibaki. Thank you so much for inviting me to this very exciting panel on AI, very timely discussion. I'm an emergency medicine physician at Children's National Hospital here in Washington, DC, and just coming off a clinical shift in the environment of COVID. I'm a medical director of informatics for digital health in our health system. We've also been involved in standing up our telemedicine program and telehealth program, and have been an investigator on several grants trying to improve access into underserved communities for getting healthcare into these communities, including both underserved communities in metropolitan areas, but also in rural areas. So looking at a combination of factors and really emphasizing the patient and family voice here in digital health, and trying to harness innovations in this arena to really work on democratizing healthcare. Thank you.
Thank you. And Renee?
Hi guys, this is Renee. Thanks for the invitation for this very exciting panel. And I work at NVIDIA, which is an AI computing company where we provide both software and hardware for many industries across the board. And my role at NVIDIA specifically is global healthcare AI startup role. And I've been in this role for about a year. And prior to that, the last 3 years, I was a product manager and product marketer for our AI systems. So very excited to be here. And we have a lot of startups in our program, more than 5,000 actually around the world, cross industries, focusing on AI solving various different problems. For healthcare specifically, which is one of the largest segments, we have about 900 some healthcare AI startups, ranging in medical imaging, medical instruments, genomics, drug discovery, and digital health. Very excited to be here. Thanks for having me.
Yeah, thank you so much. So before we get to the first question, I have to do a shout out to Aprajita Mathur, who isn't on this call, but I met her in June 2019. She's a leading bioinformatics software test engineer. We met in New York, and I was talking to her about cultural intelligence, and she looked at her research that she does around cancer research, and she talked about how each human is not just figuratively, but even literally unique. So some of what all of the panelists has mentioned before, one size fits all approaches and treatments yeah, if you could put yourselves on mute, may be very different depending on your background. So Aprajita said the concept of personalization in AI is as important as it was in precision medicine back when it started way back then. And she said, someday when my great-great-granddaughter asks Google, why do Indians wear a red dot on their forehead? I want Google's answer to be reflective of my ancestry. I wanted to include the same emotions that I would have in answering that question. And I thought it was really insightful. So in her spirit, I wanted to give her a shout out. The first question that we have today is, as you all lead innovations in healthcare in your work, what are the pain points that you see in the healthcare industry right now when it comes to reaching or serving diverse communities, especially given what we have learned in COVID and healthcare disparities with communities of color? I'm going to throw it to you, Kristen.
So I think that there is a misunderstanding around the complexity of diverse communities. And this stems from the fact that those that are leading the charge in healthcare or healthcare innovation are disconnected from diverse communities, so to speak. And the assumption is that one size fits all. However, having worked with diverse populations, I will say that there are populations who has complex needs, such as it might be a language barrier, it might be a cost barrier, population density might be an issue. And these are all things that hinders patient experience, but more importantly, it hinders a patient's ability to access healthcare. So in short, healthcare disparities are longstanding in communities of color. COVID-19 has exposed that. And I believe that now is the time for the healthcare industry to foster collaboration and partnership with non-traditional stakeholders to combat these inequities. Thank you.
Thank you. Michelle, let's go to you next.
Yeah, so when we think about diversity in the All of Us program, we think about the side of the participants, but we also think about the side of the researchers. So focusing on the participants first, we definitely learned early on in the program, before I joined the program, that they had started to try mostly doing digital enrollment, and they found that they were not able to recruit as many diverse individuals into the program in that method. So they had to think creatively of how they were going to bridge that gap. And it actually ends up being, more community involvement, getting to know what are the barriers to joining a research program, because there are definitely perceptions about research and what the program is trying to do. And so, the program is definitely going into communities and trying to dispel those myths. One of my PIF colleagues is actually working on that. So there are two. So in addition to the digital enrollment now, we've created these partnerships with healthcare providing organizations. And so then those are able to directly recruit people from the healthcare providing organization. And then to reach the diverse communities, we've created partnerships with federally qualifying healthcare centers that are, the healthcare provider organizations that are serving the more diverse communities. And so by creating those partnerships, in addition to, just kind of going into areas and starting to talk to community members, that's how we've tried to bridge that gap. But, I just think it's really interesting to highlight the fact that when you try to use a fully digital approach, you may be missing the mark, at least initially.
Yes, thank you so much. And if you could each, please feel free to put links in the chat around your research, the All of Us program, and Kristen, your work, that would be great. And Dr. Atabaki, Shireen, let's go to you next.
I'm very fortunate to be part of a health system which has as its core mission, clinical care, advocacy, research, and education. And the advocacy is really helpful. We have a full team involved in that. And one of the goals of our telehealth program has been really to help bridge the silos that exist in healthcare, which has been really fascinating to me, where my 14-year-old can easily access health information and other information with a quick Google search. It's very difficult to have that connectivity because of issues around security and privacy and other silos and barriers that were created over the years. Most of it with a good aim, but really makes it difficult to access health information in the healthcare setting. But what's been very interesting with the COVID environment is that a lot of those silos have been removed with opening up these doors. And so access to healthcare is easier than ever before, especially for young adults and adolescents, where previously they had to jump through the hurdles of having a parent, for example, schedule a visit. Now they can access their own healthcare very quickly. And so we're looking at getting back the patient through patient surveys, the voice of the patient, how these experiences go, and really letting patients and families lead the groundwork for how we're going to evolve this telemedicine and digital health approach to meet their needs.
Thank you. And this is a great transition to Renee. You must see a lot of startups who are trying to also address this issue of telehealth. Could you speak a little bit about the pain points that you see with regards to disparities in communities of color, and what startups or work that you're seeing that's innovative?
Of course. And of course, there's a lot of similarities across many different segments, not just digital health, just in terms of the bias that we're getting from the data collection area. And right now, as we're trying to find the different treatments for various different infectious disease, including COVID in this scenario, in the clinical trial world, we all know that we're limited in terms of what population we can enroll, and that really could potentially impact the results that we get. Of course, we're getting better, and we're moving towards like collecting more and more data from multiple different sources, and hopefully that will be a solved problem in the near term. And from the technology side, I do see a lot of startups, for example, actually don't get a lot of resources, no matter if it's compute resources or software resources, be able to do the lifetimes of work with a short amount of time, especially given this COVID pandemic, right? So for example, let's just use the genomic space, right? There's like about 100 some national genome programs going around trying to create these reference genomes. And all of us know that human genome is a large data set. Just one personal human genome is about 3 billion letters long. That's about like 100 gigabytes of data. So if you don't have the compute resources or storage resources or the software to be able to actually store that and be able to provide insights, that could potentially really delay the insights found during that process. But I do think COVID actually had brought together a ton of opportunities, no matter if it's from expertise or the resource side, to open the community up to collaborate together and be able to create this sort of large data set safely.
Thank you. And for all the participants, please feel free after the second question to start putting some of your questions in the chat. We'll get to them. I'm going to pass it over to Swati. Thank you. You're on mute, I think.
Thanks, Devar. Most of you had touched upon why culturally diverse solutions and personalized solutions in healthcare are important. And in the context of AI, since I work with it so closely, we often speak about the biased data sets against a particular sector or a particular group of people. But on the other hand, I always think of some of the inroads we've made in research. For example, as a woman of color and many other friends of mine, we experienced that whenever we have taken a mammogram, we've been asked to come back to doctor's office multiple times because they're not able to interpret the result as easily for a woman of color as compared to others. And I have experienced just personally, and so have my friends. But one of the good things I've heard in AI research is that it has actually made, AI has helped us reduce that error rate for women of color in detecting breast cancer. So while on one end we are talking about the biases, on the other end we can actually hone I want to say not bias for a good cause, but more about honing specific sectors of people based on their cultures or their genes, and create solutions very personalized to them. So in that context, one of the questions I would like to ask is that when we think about cultural data or cultural information, which will help us create a personalized healthcare solution, what are some of the challenges you see happening? Is it access of data, or is it, like Renee mentioned, crunching that information? Kirsten, can you add what you think about it?
Sure. So I like to think about technology and healthcare and medicine from a historical standpoint. And I think that now is the time that we have to stop and pause and think about what has worked and what has not worked. So even in creating new data sets or creating new content or creating representation in healthcare, we have to look at why there is bias, why there is mistrust. And we have to look historically at communities of color that have been negatively impacted by bias in healthcare, dated back to the 1800s, where Black women were used as test subjects in experiments, in addition to the 19th century or the later 19th century when we had the eugenics movement that really framed policy and the way in which society worked. And the communities that were impacted by these different movements, by these different injustices, were Black and Brown communities. They were the mentally ill and poor folks. And subsequently, we have this mistrust where among diverse communities as it relates to the healthcare industry. And we have the opportunity now to create a pipeline of physicians and healthcare professionals and innovators and scientists, people who will truly be reflective of the population that we serve. And I think that's a huge part, in addition to the technology, the AI, and all of the fancy creations of the future. So yeah.
Thank you. And I think you touched a very good aspect, like technology is an enabler to solve problems, and it's not just hardware and software by itself. So in that context, Michelle, I want to go to you since you're involved so much in research and leading programs in bioinformatics. What are some of the challenges you see? Especially I've heard of research where it was very much aligned towards one demographic versus another. For example, to Davar's earlier story, if there is an Asian population that's growing in a particular sector, will they bring new diseases to the forefront that is not present in the indigenous local people? So what are some of those challenges you're seeing around the cultural data that we do need to solve this problem?
Yeah, definitely. I think it's a very timely question, especially as we're starting to integrate technology in healthcare, but also in research for healthcare. We're starting to do research about, using these kind of newer technologies like wearables to try to get a window into people's health status. But one of the challenges that we're seeing in the All of Us program is that, folks that actually have and wear those devices are not as culturally diverse as the program as a whole, and certainly not as America as a whole. And so there's this kind of gap area where, it's a very exciting area of data collection, but who are we leaving behind if we just focus on that without focusing on also bridging that gap? And I think especially as, telehealth and telemedicine starts to really take off, I think we're going to really need to be mindful of that and figuring out, how are you going to serve communities? And I think, especially with what we've seen in All of Us about, sometimes you just need to go into community and ask and listen and in order to understand. And I think we might need to do that in this case as well.
No, that's a great point, Michelle. Too often when I talk about diversity, I, as a technologist, say diversity is not a technology problem. It has to start at a grassroots level, right? It has to be, if we are looking only at data sources, like you said, like wearables or anything else, like users of a particular sector or a device, we have to be cognizant about, are we taking a diverse sample of people? And similarly, is the person creating the algorithm, right? Are we diverse enough as an engineering team? And the stakeholders, are they diverse enough? Do we have enough healthcare subject matter experts who are reviewing a technology solution? Because too often as technologists, we wear the blindfold and are writing our algorithms, but we need that diversity at various points of creating the solution. So I know, Shireen, you are in the front end of all this. So how do you think that patient care, which has to be personalized, what are some of the challenges to make it personalized enough for the diverse community that you serve?
It's really interesting. We've interviewed patients and surveyed patients in our waiting rooms in inner city, downtown Washington, D.C. And have found that about 80 to 90% of the families have smartphones. So it made it reasonable for us to assume that that would mean they would have access to healthcare through that, through very simple applications that are relatively cheap to get. What's been most surprising, or the largest barrier, has really been the price tag on a lot of this remote monitoring and cloud-based storage of these large data sets that, you know, as I talked about, trying to democratize healthcare using technology. That's been the most surprising to me. You know, the price stickers are just astronomical and really not possible or sustainable to have without very, you know, integrated grants that really support these. And so we've started a lot of these programs with grant funding, but really looking at going to the patient and the family to seeing how this would be sustainable in the community and environment. And the feedback has really been to use as much basic technology or even, you know, for example, if you're using a thermometer, you don't need a digital thermometer, which could cost up to $1,000. You can just use your regular thermometer, but adapt it to a free mobile application where you can personally enter that data. But that really requires a communication and engagement with the patient and the family on a different level.
Thank you. Thank you. That was insightful. I'm currently working on a lung cancer research project. And one of the first steps was, in order for me to even access data, we have to pay around $2,000 just to get the data set, right? And that's a smaller amount compared to what some of these solutions are costing these days. But I am very hopeful with the rate at which technology innovation is happening. It will be much more cheaper in the near future. And I know, Renee, you can add much more to it since you are in that world. So your question would be twofold. One is obviously, what are you seeing trends in commoditizing these AI solutions so that hospitals and healthcare providers can afford to buy the solutions at a large scale? And secondly, the cultural data sets itself. Are you seeing any startups focused on that area? I know Devar is doing an awesome job with Evolve, her startup, focused on cultural AI, but are there other startups in the healthcare space you would like to talk about?
Sure thing. I think just to go to the first question related to how does the healthcare ecosystem be able to continue to leverage either democratized AI solutions to be able to advance forward, what are some of the trends that I'm seeing? I do see a lot of the smaller startups are leveraging bigger companies' partnerships to move forward, and the Savvy startup definitely is moving forward like that. For example, at NVIDIA, we created a Clara application framework. One of them is specifically targeting the imaging space. So we actually work with NIH very closely and announced one of the application framework available for the community to continue to advance, understand, and measure, detect infections of COVID. So this data set was very, very important for like about 200 some medical imaging startups specifically, because they don't have access to patient data, but a big organization like NIH does. So big partnerships formed together in the Valley and globally enabled a large group of innovators, developers to be able to develop on top. And of course, only just developing solutions is not enough. They also have to figure out how to fit it into the workflow. How does the administration, who's going to reimburse them? All of that is a lot of work for small startups to figure out. And on top of that, of course, is the data set diversity, which is very, very challenging for a lot of startups because a lot of them are struggling to find funding to get their solution off the ground. For them to do a quick demo just to say that, hey, my solution works, that of course is only built on top of a small set of data set, right? And I will even encourage, I think, beyond this panel to think diversity is not just diversity, it's also inclusion. Because you can think, oh, I want Chinese data sets, Indian data sets, that's diversity. But that's not inclusion of many other data sets a company that really needs to include in that. So startups are thinking about that, so they're leveraging a lot more data set as they could to continue to advance their work. And case in point, one of the startup whiteboard coordinator based in Chicago They essentially do video intelligent analytics and conversational AI to put these digital windows, as we call it, into the hospital's environment, be able to keep the staff safe. And in that scenario, when they were working on the conversational AI piece, partnering with us, they are hoping, the first immediate question is, what language is the pre-trained model trained on? Is it only language? What if I have a lot of Filipino or Mexican people in a hospital? What if they have accents? Then what, right? So questions like that is very relevant for any startups to tap into. And as big companies and technology providers in the space, if we decide to enable an entire ecosystem of startups, those data set diversity, culturally inclusiveness is extremely important.
That's interesting you said that, because as voice is becoming more and more, used by future generations, like my 4-year-old thinks Alexa is his friend. So we want to make sure that you are as inclusive as possible, and that shows the direct economic impact of culturally diverse data sets. So thank you for that insight. Over to you, Devar.
Yeah, thank you so much. And we look forward to responding to the questions from our audience as well. But I think as I've heard everyone speak and reflect, I'm transported back to the tiny island nation of Timor-Leste. I visited that nation. It's only 14-year-old country, and 52% of the kids have stunted growth. And there's a lot of issues around malnutrition. So when I drove up mountainside 4 hours to get to a village to meet women who were created a sustainable garden that fed healthy food to not only their own village, but surrounding villages, and enabled them to be self-sufficient and self-reliant. I said to them, if we were to create any stories around healthy eating using Timorese ingredients, how would you even watch it? And this is when this is a magic conversation, because they said, we would have Facebook film nights on the smartphones of our teenagers. This is what Dr. Advocacy is talking about. They went to downtown Washington, D.C. and surveyed communities of color, understood that 80% had smartphones, and said, okay, if we were to create a solution, how would you use it? This is the issue. The issue is what Kristen talked about earlier. We have to pause. We cannot imagine that only the startups that have access to Silicon Valley have the answers. In fact, this is my next question. What should we do? If we pause before we create more AI solutions, what should we focus on? And that's what I'd like to ask you. So maybe Michelle, I'll go to you first.
Yeah, I think it's an excellent point, Devar, especially, like we've been talking about with the coronavirus epidemic happening, in telehealth being more necessary, we absolutely have to build technology that's capable of serving all Americans and all diverse individuals. I think also the pause needs to include an understanding or a plan for research and testing, because I think with any new technology that you create, you really want to understand, how is it going to impact people? And I think that even more broadly with technology, even beyond healthcare, I think that there's a need for more testing about how technology is impacting individuals and impacting their health. So I think that it's a really important thing that we really need to pay attention to and figure out how to do, but from a research perspective.
Yeah, so funding experimentation and learning specifically on how you test technologies that would work in communities of color for access and for cultural relevancy and respect. These are some of the issues that we also have to discuss. This is not, again, just a technology solution. However, guess what? Thousands and thousands of Stanford grads, don't mean anything bad about that, are creating applications that they think are going to be useful. And in fact, they're going to set us back another 10 years because they're addressing the same issues that exist right now. So Kristen, let me throw it to you, and then Shireen and Renee.
Sure. So I've worked with underserved patient population, and as a Black woman myself, has experienced bias in medicine, like I mentioned before. And I think that we really need to create culturally inclusive narratives and stories using technology, AI specifically, because this can absolutely enhance the patient experience. And data can help personalize the individual's experience. Even more importantly to that is it could have positive impact on behavior change. However, we have to be careful that we're not using culturally sensitive patient data to exploit the already marginalized communities. So pausing potentially means listening to those patient populations that are already marginalized. And also in that pause is, how do we look at policy? Because policy sets the standard, it sets the stage of how these data sets are going to be used. So the solution is to have policies that protect the user's data, and also people of color that are creating these solutions needs to be involved in funding, and they need to be recipients of funding of those solutions. And as I mentioned earlier, as a woman of color that have experienced bias in medicine, I've created a tool where my voice would be empowered in my experience. And I'm very calculative about how we're using that data, ensuring that we're not exploiting those patient population to begin with. So I hope that answered the question in terms of what that pause looks like.
Yeah, absolutely. Thank you. And Dr. Advocacy, I mean, obviously in the world of COVID, you don't have the luxury of pausing. You know, you have to continue taking care of your communities. But in fact, as medical director, you have gotten research grants, which means that there is a possibility of thinking of what this pause would look like and going to agencies such as NIH, CDC, others, even Renee. I mean, you can go in the startup investment world and say, if we were to use the example of COVID and the urgency that it brings, requiring us to be a lot more better stewards of how to do the next generation of healthcare, especially with AI. As a practitioner, doctor yourself, how would you even approach that?
That's a great point that you bring up. I was thinking about that as my colleagues were talking. Is the opportunity for a pause. You know, in response to COVID, we were able to really rocket our telemedicine program, and had to do that, you know, from about 80 telemedicine visits a month to increase it to about 13,000 visits a month within a week. Really didn't give us a lot of time to you know, pause and think about it. Although we had laid a lot of the infrastructure and the train tracks before this. Part of the reason we were able to do that so quickly from an operational perspective was because patients and families are so familiar with the technology. And it's interesting, as time went on around, you know, our being faced with the COVID pandemic, we saw that people were more and more comfortable across generations using the technology that we had, the basic technology for telemedicine, because they were doing it in their homes. They were doing it with family and friends. They were using it on the social media settings. So I think that was a very good lesson learned for us, which we hadn't realized would really help us transform this so quickly. I do think that it's fascinating. People talk about the silver lining around this pandemic. Part of it has been the ability to get back to the old-fashioned house call. This lets me go into a patient's home directly, where the venue and some of the go-betweens between a patient and a provider or health system have gone away. You know, you would have a registration person getting intake, or a nurse asking questions or doing vital signs. Right now, it's you and the provider in the patient's home. So right there, the culture of the visit has changed because you're in the patient's home. You're in the setting of their home, you know, their sacred space. There's a lot that we are learning from this and really trying to get more and more input from patients and families.
Amazing. And Renee, I think you definitely exemplify an investor and, you know, in the startup ecosystem, somebody who's really incredibly inclusive and really want to make a difference in this space. But that's not the case for many investors. Many angel investors, many VCs are really only looking to invest in companies that are going to make money right away. And so the idea of pausing, even though to a certain extent, investment has paused during COVID for obvious reasons, but could you kindly talk about what that pause would mean? How can we pause and shift and think about thinking of communities of color as the producers of these technologies, as the thought leaders behind the production of these technologies, as opposed to always being the recipients of flawed technology?
Sure thing. So one point to address is there's definitely lots of investment pause, but there are also some of the startups are closing millions of dollars on a weekly basis, mainly just because of the extreme need in this very difficult time. So I think for the startups on this call specifically, if you guys are looking into targeting certain areas, there's still hope for sure. There's still investments around to try to support you guys. So that's one thing. And I think addressing the communities of color or diversity or inclusion, this is a very good opportunity to take a pause to really think about how the society as a whole is moving forward and how the entire culture is actually changing. I'm saying this is because I remember in 2017, I think, there was a research that was done between the Institute of Creative Technologies with UCLA and Carnegie Mellon of Computer Science. They actually put this research together to say that, like, okay, the military service members actually came back with PTSD symptoms, right? They will actually prefer to talk to an avatar, which is a virtual human instead of a real human, because they feel more comfortable asking about these stupid questions instead of getting judged. Now, just let that example sink in a little bit, right? That's actually a very good story for all of the technologists in the world to think about. Because what does that really mean for us? Does that mean those people who actually built the avatar is trying to smooth out the edges and put the best humanized voice into these avatars to make people think that these AI machines are actually a lot more approachable? Or does that mean maybe as our society is continuously changing, where so many of us are attached to social media, where many of the millennials are completely drawn to instant gratification, which is making the entire society very much becoming very impatient about being connected with people and having this very high EQ, if you will, to be able to provide relevant content or conversation back through a screen or a telemedicine, right? Or telehealth as an example. So with that, I think this is a very good time, especially for the folks who are building solutions out there, to really think the more IQ you're feeding an AI system, the more EQ it needs to have. And this EQ really comes from that the more you automate these systems, the more you have to educate it when, where, how, and what, and its cultural relevance to enable a bigger population in the future.
Wow, that's so mind-boggling and awesome. I'm going to turn it over to Swathi to share some of the questions, but I did want to share a couple statistics that were relevant. So something like 38% of millennials say that they are willing to take advice from a chatbot. Okay, 48% of Americans say that they will take advice from a chatbot. The point here is, yes, maybe they're talking about the weather right now, right? But the moment it turns into something deeper, which, by the way, it will, we won't be there again. People of color will not be there. And it's because we didn't have, like, philosophically a decision between policymakers, technologists, communicators, creatives to say, okay, how are we going to pause and inform this next generation? If these statistics are true, don't keep creating these conversational AIs that are going to tell you where to buy pizza. Think about it more strategically. Talk to Dr. Advocacy, who's like at the front lines, and Kristen and Michelle, the researcher, and Renee, the investor, to figure out how you can do it so that it's going to have the most impact and revenue, right? Because in the end, it's about money too. So Swathi, over to you to respond to some of the questions that are coming in.
Sure. Thanks, Devar. I think a story that Renee just mentioned resonated with me. In his recent book, Talking to Strangers, Malcolm Gladwell cited an AI research project where 500,000 people that were judged by a judge in New York City about letting them go on bail or not, right, were later analyzed by an AI system, and the recommendations given by AI system turns out actually committed 25% lesser crimes because they already had the data by the human judge, right? So that is one example where AI system cannot actually see and judge a person. It only is making the recommendation based on past historical information and some of the input variables. So there is still hope, I think, but as to your point, Davar, and all the esteemed guests here, too often when I am sitting in a technology conversation and strategizing AI solutions, one of the things I do bring up is why are we not having your legal team and the HR team? There is an impact to your human workforce. There is going to be an impact where the AI system has to be justifiable in a court of law of what would happen. And I am met with resistance. And this is a true story that too often they think AI solutions are in the hands of a technologist. And I always go back to the board and say, technology is just an enabler, but we do need to have those diverse people on the team to ask the right questions. Having said that, I'll go to this chat window, and there are some very interesting questions. I'll start off with the one from Eileen. Thank you, Eileen. Question to Kristen. In working with so many patient stories and patient advocates, what have you learned about health experiences that benefit from patient voices? And I wonder if any patterns arose and anything surprised you, Kristen.
Yeah, so my work is, when I started collecting stories in the streets, very ethnographic, doing interviewing and really listening to what folks were experiencing. And I was really stunned that across the board and across racial barriers, so people of different racial background had this one commonality, which when it comes to healthcare costs. And that stunned me because we can all assume that different groups of people have more access. But when we look at poverty and the way in which that impacts a person's ability to access healthcare, that really tells a strong story about healthcare spending and the fact that we really need to address social determinants of health. And I think that's always been something that has kind of motivated me to build a platform that we've built, and always an eye-opener.
Thank you. Anyone else? Michelle or Dr. Shireen, Renee, did you want to add anything?
You know, I think one of the key things that we've learned is the need really to include implementation science and that work that I love the EQ component. You know, we don't really usually use that in clinical research settings or proposals, but I think I'm going to start adding that, you know, on the implementation piece. I think that's very important to include to make sure that the tools we're using for remote monitoring, for example, are accessible. We recently were awarded one of the FCC grants for COVID-19 telemedicine response. And part of that project is to establish a regional telemedicine coronavirus response consortium. And one of the big pieces includes getting remote monitoring out to communities and individuals who are underserved, and really looking at what types of devices people would want in their homes. What would they want to use personally based on, you know, past patterns, but also going back to them to look at as an investigator, researcher, but both on the operational side. I think what would be very useful is establishing some joint or collaborative definitions around some of this. So that we have some of this predefined and each of us doesn't have to go back and try to recreate the wheel. I think having some a basic foundation around this conversation is very important and something that we can build on and can adapt to And again, the nice thing about digital health and AI and telehealth is it can rapidly evolve and change, and you can easily change the components that go into a health bot. For example, for a COVID-19 response, which is something we've stood up, but we anticipate we're going to have to, we've already changed it a few times over the course of the last month.
Thank you. This next one, I can go to Michelle. Mahalakshmi asks, I think diverse data sets and explainable AI without bias can in certain way help reduce the bias and not so diverse medical professionals can bring. Is there work around this, Michelle?
Yeah, I definitely agree with that. I think that the crux of it is having the diverse data set and being able to look at that data set in a light that's going to expose those biases and allow you, to really individualize medicine in a very unbiased way. And that's certainly the goal of the All of Us research program. And it was created because we noticed that across all of the clinical trials, the majority of clinical trials, we weren't seeing the diversity of the American people there. And how are you going to, if you're only doing research on a single type of person, and then you're trying to apply that research to everybody, it just is not one size fits all. And so I think that, AIs have to be the exact same way. But again, you have to have the data. And I think, one of the things that I see happening is a lot of this kind of AI-based research that has a lot of data happening only in the private sector. And I think one of the things that we really need to do is we need to democratize that a little bit as well to the research community and create more public-private partnerships. And so, as I was talking in the beginning about how all of us has tried to reach, diversity in terms of participants, we also are doing a lot of thinking about reaching diversity in terms of the research community and being able to make the data available to a wide audience. We have a public data browser, and then just in the last month, we released a registered tier of a researcher workbench that has the individual level data. And those data are available to basically any researcher that has an ERA Commons account and that their institution is willing to sign on. So I encourage you to go take a look. At this moment, we don't have a platform that allows citizen scientists to do individual level research because we're always balancing the concerns of privacy and security for our participants as well as access. But hopefully we will find a way to make that available. And I think that we need to push, private industry that's creating a lot of data to try and do the same.
Yeah, thank you, Michelle. And that is a challenge. Too often industry or private commercial organizations are afraid that their innovation or the secret sauce is taken away, but I don't think so. As a technologist, I know how we can strike a balance between sharing enough of open source information and shying away from the secret sauce. So I think that's a conversation we should have more and more. So Renee, what are your thoughts about diverse data sets and explainable AI? And what are some things you're seeing in healthcare startups?
For sure. So from the explainable AI perspective, there's definitely still this black box around, but there are a lot of startups started trying to put in mechanisms in place to at least figure out like why certain neural network is performing a certain way. And of course, we're constantly being reminded that AI can't solve everything. Sometimes a very simple graph analytics can't solve the problem that you need to solve. So from that perspective, I think as soon as any startups or any companies identify a problem, do think about like what is actually absolutely needed to solve certain problems. So that's one from the explainable AI perspective. From the diverse data set perspective, I would say that like as we can earlier already mentioned about the diversity and inclusion of all of the different data sets, but from the privacy perspective, there's more and more companies trying to blur out patient spaces and be able to make sure to maintain that layer of privacy even when they're collecting the videos, right? So another company they're called Milan. Actually another trend that I've seen is actually many other startups in other industries, because were able to largely scale and deploy it in other industry, they actually have developed a healthcare specific solution as well. So Milan is one of that example. So Milan, this company, they ended up putting this very beautiful solution together where they're able to detect mask, your temperature, and also social distancing all at once. And they will automatically be able to send a phone notification if someone, for example, took off their mask and also have very elevated temperature. And when a physician or whomever is at the front door get a notification on the app, you will see immediately the face is actually blurred out. So they combined a couple different technologies together to enable to help make either patient or physicians safe in various different environments. So from that perspective, sometimes we might also even think about maybe diversity is going to be in the future because of the patient privacy. From that perspective, it will bring to a different level. Of course, the initial training data set might be very different, but the eventual end outcome, it probably doesn't matter whom that person is. As soon as the model is trained, that can actually serve a big population. But then the end goal, when you see someone, it's just a patient. It doesn't matter the color anymore. It doesn't matter whatever it is, and the best outcome, the best solution, the best insight will come out of the very thoughtful solution that's put out there in the market.
Thank you, Renee. Michelle has a question. Devar, are there any personal coach, diet fitness, chatbot implementations that already leverage culturally relevant AI? And if so, what can we learn from this? I will add my 2 cents and pass it on to Devar. It's not a chatbot, but I'm aware of some advertising agencies use culturally diverse data sets using natural language processing, because advertisers are on the forefront of this, right? You do see that they do have, the good advertisers at least, have culturally relevant advertisements. Me being an Indian living in the US sometimes do receive advertisements around Diwali and so on. I know Hanukkah is huge here. So advertisers are using not a chatbot, but at least natural language processing to extract the cultural data sets for targeted and personalized advertisements. I'm aware of those solutions that exist. Devar, did you want to add other examples?
Yeah, I mean, I think a lot of that is currently, honestly, being developed. It's a very nascent field. There are AI culture storyteller experts in academia, and thankfully they're all my advisors, like some of the top in the country. But I want to maybe leave with this thought. Machines know zero until a human teaches them something. So I'm going to talk to our AI. Hey, Google, get me Sina Storyteller.
Let's get the test version of Sina Storyteller.
Hello. My name is Sina. I am iVow's digital storyteller. What would you like to learn about today?
Who thought about quarantine as a way to control a pandemic?
The Persian scholar and physician Ibn Sina first suggested the idea of quarantine to prevent spread of diseases. In the 11th century, he suspected that some diseases were spread by microorganisms and came up with the method of isolating people for 40 days that he called Al-Arba'iniya, the 40.
Okay, and of course, Sina knows a lot of other things, but I taught that, and Kim Oleski on this call and Nisa on this call from iVow, we're former journalists, or you're always a journalist once you're a journalist, but we're teaching chatbots to understand cultural context. So it's really just the beginning of this arena, and I'm so incredibly inspired by all of the remarkable conversations that we just had, and I hope that it's just the beginning because there's some incredibly powerful and smart women who just shared their knowledge, and I think we can learn so much more. We've run out of time, so we're not able to take any more of the questions, but just wanted to thank everybody for being present. I wanted to acknowledge Ujwali for all of her contributions also to our virtual event, and just thank you each for being here.
Thank you, all of you. And Ujjwala, yeah, she's an evangelist for the community. So thank you again. And we will see you for the next event. Have a great one.
Thank you, everyone. Goodbye.
Thank you.
Bye.
Bye.